Dia Walker, and for those of you who don't know me, I am a physical therapist who specializes in correction or natural correction of foot and ankle. So first things first, can everyone hear me?
Yes.
Yay, all right. I love hearing that. Woohoo. I am also self-admittedly technology challenged. So I am praying to the technical gods above that this will go smoothly as I'm trying to attempt to stream live on Zoom as well as on Facebook. Not Facebook, I'm sorry, I usually go Facebook. Today, for the first time, I am going on YouTube and I have no idea whether I'm there or not. It says I'm live on YouTube, so that's all good. I don't know if I'll be able to answer questions from there or not. So if you do write a question, I'll be sure to get to it. Maybe I'll even do a YouTube video on it, so you can always write your questions or comments there. So I see some familiar names in my group here. And so some of you do know me, but again, for those of you who don't, I'll tell you a little bit about my background, and some of you may know this or some of you may not, is that about 5 years ago, in 2015, I decided to figure out why bunions happened in individuals. And so I developed a course, an online course, my first one, called the Bunion Solution. And that course really kind of morphed and developed as I developed with my skill set and also with my knowledge, and then also working with clients and patients, both online via telehealth, as well as, in clinic. So I have developed leaps and bounds since 2015. And now I am on Bunion Solution 3.0, and I've developed kind of a functional bunion test so that people can determine their bunion type and really try to gear programs to make them as efficient as possible so people can get the greatest bang for their buck and the quickest results in the shortest amount of time. So I will be doing a very quick PowerPoint presentation, and then I'm going to go ahead and show you my signature release technique, which is, I think, kind of what makes my programs different than conventional bunion correction. So I'll go into that a little bit more right now, actually. It is a lot of bunion braces or orthotics, those kinds of things. What they do is they do something called realignment. Okay, so they try to correct the alignment, and so do I. Alignment is key. And in fact, if I could make the world a better place, if I could make people more structurally sound, I would correct their alignment, because I'm going to get into that in the presentation. So that's really important. However, if we have just, I'm going to show you our little skeleton here, just in these joints forward to the tip of the toe, the forefoot of the foot, there are 33 joints. So there's like over 50 joints in the entire foot. And each joint in the entire foot, for the foot to work optimally, really actually needs to have mobility. And what has happened with modern society, okay, is that we grow up wearing shoes and walking on flat terrain. Whereas when we were cave people or early man or indigenous cultures, we had minimalist shoes as babies, children, right? So our feet developed differently. We were able to maintain the mobility in the joints, and even when we were walking on uneven terrain, would even release or mobilize, which is what we're going to do in this class, these various different joints. And then if we were climbing rocks, our foot would have to accommodate to the rock, climbing trees, et cetera, et cetera. So, there are individuals who have been born without hands, And they can use their feet to do everything that their hands can do because they've been doing it at an early age. So there's some neuroplasticity there. And so that means that our feet have incredible capabilities that we don't take advantage of. And I have a saying that if you don't use it, you lose it. So what happens over time is that if these joints don't stay mobile, okay, and certain athletes like gymnasts or figure skaters will probably have pretty good mobility, gymnasts in particular, because of the balance beam, those areas will not maintain their mobility and they will become kind of stuck or rigid. And that's what happens through our body. So if it's kind of like if you've sat in a car for about 8 hours, right? Or you're taking a long drive and you get out of the car and you're like, oh, you're kind of walking like all stiff. That's really kind of what happens on a microscopic level or smaller level in the connective tissue throughout these multiple 50 some odd joints in the foot. Okay, so that's just a little bit about me and my background, but I'm happy to answer any questions. So you can always put them in the chat box, or you can go ahead and unmute yourself and just go ahead and chime in. Great. All right, so I'm going to go ahead and attempt to share my screen, and I'm going to put on my PowerPoint here. So again, a little bit about me personally is that I have a goal or mission to resolve foot pain and dysfunction for over 1 million people. Because I think, I'll tell you, because I have a belief that it's all about the base. So our foot is our base of support. It is our foundation to our house. It is the wheels of our car. It is, if it is not functioning properly, everything that comes above it is not going to look very good. So here's an example that when you have poor alignment in your foot, it's like a house that's built on a crooked foundation or one that has a sinkhole underneath it. Okay, everything above it is not going to be sound and sturdy. Or it's also like driving a car with a flat tire. So if you think about when you get a flat tire, what do? You pull that car over immediately. Why? Because if you don't, everything else in this car is going to break down as a result of that flat tire. So most of us are either walking on flat tires or tires with low air, so to speak. So restoring the alignment in the foot will impact everything going on above it. Every system, every joint. There have been, I remember a situation where an Olympic diver, a platform diver, was having vertigo. And she went to an osteopath. It turned out her dysfunction causing the vertigo was in her foot. So honestly, it affects everything going on above it. And it's also our base of support. So if we lose balance, and that's kind of how I got into the foot as I was teaching a balance enhancement and fall prevention class, our foot is our base of support. And we fall when our center of gravity moves beyond our base of support. And our feet in standing are our base of support. And most people do not fall when they are sitting down or on hands and knees, etc. They typically don't fall and hurt themselves. It's when they're standing. So again, having good mobility in the joints of the foot will allow for greater movement above that area so that they can go ahead and be able to sustain perturbations in the body over, and their base of support will remain sound, being their feet. So this is something that I learned in graduate school. I have a graduate degree in exercise physiology, and this is a concept from exercise physiology called the length tension ratio. And what it states is that a muscle will contract with greatest vigor or strength when it is at a particular length. If it is too long or too short, then it will not work optimally. And this is where alignment comes into place because our muscles are attached to our bones via tendons. So if the bone is off, like in a bunion, right? Those muscles that attach around those areas and the foot in general those muscles will not be able to contract with the greatest amount of vigor or responsiveness, again, if we're talking about balance enhancement and fall prevention. The second thing about alignment is that we have a bone called the talus, and it is it is where the upper body or the skeleton of the rest of the body meets the foot. And this bone is really interesting from an energetic standpoint because it generates an electrical field, okay? And it has the second highest measured electromagnetic field next to the heart. So it's said that when force is placed on this particular area, it generates a response to tissue regeneration, adaptation, and circulation. All right, and lastly, when we're thinking about alignment, we can think of our body, right, as a system of tubes and wires, right? The tubes are arteries and the cardiovascular system, and the nerves are more like the wires, right? The conduction system. So think about it. If you're trying to hose your garden and that hose is kinked, you're not going to get as much flow through that hose. So some people will develop numbness, right? And it could just be that their cardiovascular supply or their neurological supply could be impinged by a connective tissue issue or constriction. One place that this is very common is in the wrist and hand, and it's called carpal tunnel syndrome. So you can get something akin to a carpal tunnel syndrome, even on a small level, in the foot and ankle as well. But if you're in good alignment and you have good mobility in the connective tissue, then it's not impinging upon these tubes or wires. So I say that alignment dictates function, frequency, and flow. Function, because of the leg tension ratio that we talked about, frequency, because of the electromagnetic field and force production, and then flow because of circulation and nerve conduction. So again, I mentioned already how important alignment is to the functioning of the body and the foot in particular. And that is, again, something that is achieved with an external device, like an orthotic or a brace. However, if the joints, all 50 some odd joints in the foot, are not able to move and mold accordingly, then you're not going to be able to achieve optimal alignment because there will be compensations. So we need to kind of disassociate all of those particular joints so that they can kind of move independently to kind of remold the foot into a way that optimizes alignment. And that is achieved by release. And that's what I'm going to be focusing today's lecture on. So moving on. Okay, so why do people have bunions or malalignments? And the reason that I came up with is kind of like any other reason people have a malalignment in their body or in their posture, right? And that is, we are a manifestation of our compensations. So for example, if we're lacking dorsiflexion or the ability to get the foot on the ground flat in a flat way, we will go ahead and accommodate for that by arching the back in a lumbar lordosis or hunching forward with a forward head posture, or sometimes our knees will hyperextend. There's a variety of different compensations. And those compensations are basically precipitated by or done for a particular reason. And I came up with two of them. One is to balance and not fall. So our primary balancer in the foot happens to be the big toe. So I have found that the human body will do anything to get its weight over the big toe. And so that means postural accommodations above, as well as changes within the foot alignment. So flat feet, for example, is the body's way of getting the big toe on the ground, but that is a different lecture. The second is to keep the eyes on the horizon. So you will rarely see somebody who has a scoliosis, right, with their head tilted to the side. Their head is upright because we need to balance or keep our vestibular system, our inner ear system for balance. We're in a planar direction so that that vestibular system can function optimally and keep our eyes on the horizon. So those are the two reasons that the human body will compensate. So the number one reason I had mentioned this is to get weight over the big toe, and I already talked about that. So we have different kinds of bunion severities, okay? Some are mild, moderate, large, and severe. And obviously the longer something's been going on, the more difficult it is. So that's kind of the traditional evaluation, but I did a functional bunion assessment. Now, some of you who are on my mailing list would have gotten this assessment to do ahead of time. So you were able to kind of prepare if you did. And if you didn't, we're going to talk about it a little bit. So the functional bunion assessment is designed to figure out how your body is compensating and causing a bunion. So when you do this exercise, all you need is a pen, a piece of paper, and a marker. That's it, pen and piece of paper, and your foot. And I kind of made up different types of bunions, okay? So I have a midfoot bunion, which is more around the arch of the foot, okay? I'll get into that a little bit later when I show my skeleton. Or a forefoot bunion, which is more towards the toes, okay? So, or a walking bunion. I also call it a big toe or walking bunion, not toe walking, but toe or walking bunion. And that's where the big toe really deviates. So the way that we kind of assess this is that we just do a tracing. So on the picture that you see on the screen, that would be my right foot. And what I do is I just drop the marker directly in line with my ankle bone, at the height of my arch, at the bunion, and then at my big toe. And from that, I can kind of get a sense of what's going on in the foot, because ideally all those X's will be in alignment, in a straight line. So when they're not, it tells me something. So what does it tell me? These are the directions that I just mentioned, okay? And you can feel free to do this right now if you'd like, okay? So again, we're just marking the various different points, and then we take the foot away. So here is a midfoot compensation, okay? So what happens with a midfoot compensation, okay? And I will just go ahead and stop share for just a moment to show you what I'm talking about by the midfoot. By the midfoot, is these small, little, kind of oddly shaped bones is the midfoot, okay? These long, straight bones, they're called the metatarsals. That's the forefoot. And then I'll explain the walking bunion in just a second. So going back to my screen, this is what I would call a midfoot bunion. This is the small little bones that are around the arch. And how do I know that? Well, in a midfoot bunion, okay, those little tiny bones, remember I said that when we develop, in an indigenous culture or as cave people, those little tiny bones were moved and mobilized by walking on uneven terrain or rocks or those kinds of things. And for those people, their heel, okay, so their ankle, right, is here, but then there's a movement or a dot that goes inward at the arch where those bones are located. Then the bunion goes ahead and sticks out, but the toe is pretty much in alignment with the arch and basically the heel. So theoretically speaking, I try to, when I'm addressing bunions, I try to pretend that I am a sculptor, right? So if, and I'm going to go off the screen again, I'm going to go here. If, okay, these bones right here are narrowed and there's not good mobility or space in between them, right? This metatarsal, which is the key player in all bunions, every bunion will have a metatarsal dysfunction. It will go ahead and deviate outward. Why? To widen the base of support, because when we're walking, we are walking over the big toe. And if this is narrow, we can deviate a little bit on this end at this big, at the bunion joint. So theoretically, if we even out this area so that it's in line with the bunion, already the toe is in alignment, right? So we just really had to focus on widening this area and possibly creating some more space in between these flat bones called the metatarsals. So back. All right, so that is a midfoot compensation or a midfoot bunion. The next one is a, sorry. So here's a little before and after, okay? So these pictures were taken 2 weeks after, doing some mobilizations. And if you will take a look here, so there's a couple of things that you can note. One is that the big toe is really turned out in this before picture. Again, a significant bunion here and a pretty severe angle here. Now, don't get me wrong, this person still has a significant bunion. However, there's a little bit more space here. It's less severely pointed, okay? So if you look here, it's like a kind of a rigid angle, whereas this is more of a curve. And the big toe is not quite turned as much. And another thing that we'll look at is spaces in between the toes. Now, if you notice, this person actually has a hammer toe, which is often accompanied by a bunion. And the reason being, oftentimes, is because when the big toe, which is the primary balancer, cannot balance, the other toes will grasp into the ground to compensate for that and try to accommodate for balance. Remember, we're a manifestation of our compensations. Compensations are caused by keeping the eyes on the horizon or getting weight over the big toe because it's the primary balancer. So here's a forefoot compensation, okay? And the forefoot compensation is when basically everything is in alignment, the arch, the ankle bone, and the toe, but then the bunion just sticks out, okay? And this one would be the forefoot bunion or the forefoot compensation, forefoot driver. This one is a little bit more of a walking bunion, which I'll get into in a minute. So this guy, what happens here is that, and notice also, remember I said about the hammering of the toes, look at the difference between this foot and this foot with regard to the four lateral toes on this. So this person is not getting weight over their big toe as well as this foot. So again, here's the ankle, here's the arch, and here's the toe pretty much in alignment, but then this metatarsal is sticking out. So what I typically do is, again, I'm a sculptor. So what would I want to do? I would want to make this my, to get this metatarsal in alignment, I would want to go ahead and where it starts to come in, which is right about here, I would want to work this connective tissue, which we're going to do later, to try to get it in a little bit more better alignment, okay? But I will also need to create space between, see, look at how these toes are tight together. There's not a lot of space in between each metatarsal, okay, as well. Okay, so that is, and when I say metatarsal, I'll show you again. So the forefoot bunion is primarily a compensation of the metatarsals, right? Because the ankle, the arch of the foot, and the big toe are in alignment. but this guy sticks out a bit, okay? So what the goal is to create space to get this bone so that it is in line with the ankle bone, the arch bone, and then the toe. In order to do that, we want to create space in between these various bones of the forefoot, the metatarsals. Moving on. So this was the next slide. Okay, this is just, again, after 2 weeks. So on 331, this was the example of, this one was the one that had the most dramatic change. Although, again, this is sticking out a little bit better. There's more space in between the toes. And you can see more of the toenail on the after shot versus the before, and a decrease in the bunion angle here. And again, this was a different kind of bunion. This one is more of a walking bunion. And again, guys, you know, it's never just one thing in the body. It's usually multiple things, but there are certain things that matter more than other things. So that's what these delineations are about. So here is an example of the walking or the toe bunion, right? So with these guys, right, it's the toe that's majorly, the bunion's deviated a little bit, but the big toe really angles inward, okay? So this is something where these individuals, when they're walking, they're bringing their knee on the inside of the foot at the metatarsophalangeal joint, and they're getting in every step that they're taking, they're getting increased pressure and wear and tear on this. And the toes have accommodated by moving inward today. And so that is what has happened with these individuals. And for these guys, the issue is really kind of at the lower leg or even at the thigh. So those connective tissues need to be worked more accordingly to go ahead and create a better alignment above the foot so that the gait pattern is more normalized. And then there's some techniques that can be done to try to get the big toe in alignment as well as the other toes. So this one is the biggest bugaboo to try to correct, because again, it's reinforced with walking. It is a problem of the lower leg. So you really have to change a lot of dynamics going on here. So that one is the toughest one to treat, but it can be done. So here is before and after from 2 weeks again. So looking at the different angles of the big toe joint and seeing the now created space in between the toes. This is the bunion that will cross the toe eventually with their compensation. So again, none of these guys are going to have optimal balance or optimal gait pattern, particularly this one. And when you have a walking bunion, because you're not achieving great push-off, which is the phase of walking that involves the big toe, that reinforces motion, normalized motion at the hips. So these individuals will oftentimes have a lot of hip problems, as well as knee problems, because again, there's a rotary component in the lower leg that will factor into it. And this is an example of the walking bunion. So here's when this person is pushing off, see how the knee comes this far, all of this weight is coming in on the inside. And then when we improve the alignment here, it can come closer to midline, and then even optimal alignment. Here's with some kinesio tape, which is what I usually typically use. Now, that being said, the driver of, and this person actually is a tennis pro who had 6 knee surgeries. So hopefully she hasn't had to have another one. I don't think she will after this. So again, you can see that deviation, that rotation in the lower leg, but a lot of times it will be driven by these small little joints in the metatarsals and the tarsals. So this foot really needs like a major overhaul in order to get better alignment strategy. Okay. So again, ideal alignment is the goal of the intervention, and that is standard with natural bunion correction, as well as surgery, as well as orthotics, as well as bracing. Ideal alignment. We just go about it a little bit differently. So the goal is to remove the root cause, restore alignment, and then rebalance the system. Okay. And the nice thing about bunions, or the nice thing about treating the foot, is that rebalancing the system, when you're in a good alignment, all you really need to do is walk. Some people with a walking bunion might need to be conscious of their walking pattern, because it's going to be, you know, they've been doing an improper gait pattern for a long period of time, but they kind of had to. Okay. So what I wanted to go ahead and do is go on. Let me stop share for a second. Yeah, question. Midfoot compensation bunion, right? Because my toe isn't deviated, you can see the space made. Okay. Yes. Okay. Amazing before and after pictures. Very good. Very good. Very good. Okay. Awesome. Okay. Any other questions before I keep going? All right. So I will go ahead back and get back to here. So, all right. So there's a couple of misconceptions that you can't do anything to change foot deformity. And that is not true, because connective tissue is malleable. And therefore, so if you've ever done gross anatomy, like I have, or if you're a surgeon, you will know this, is that if you remove the bone, right, from the skeleton would not fall down into a blob, right? It would maintain its form because of connective tissue. So again, does the bone drive the connective tissue, or does the connective tissue drive the bone? Therein lies the question. So again, if you can create movement in the connective tissue, then you can kind of realign as best way possible. Now, that being said, there are going to be adaptations that occur, like ligamentous laxity, that those ligaments or those connective tissues might be stretched so much. It's much easier to release something than to shorten it or to make it tighter. Okay, tighter usually involves some sort of surgical intervention, but releasing, creating movement is not difficult at all, and I'm going to show that to you. And then the second misconception is, so we do this through three different steps: release, realign, and then reinforce. So release is releasing the connective tissue, ideally all 50 some odd joints in the foot and the lower leg. And then we realign, okay? And again, that could be done with orthotics or braces, or I like to use kinesio tape or various different kinds of tapes. And then reinforcing or rebalancing is just going ahead and creating a neuromuscular pathway that teaches the body how to now work properly. Okay, but you have to give it that motion, guys. If you try to, you know, and this is what happens when people exercise. When they're exercising, we again have all these compensations. So it's like I say, trying to go ahead and serve a tennis ball if you only have this much range of motion in your shoulder. You'll never be able to straighten, go all the way up, and be able to, because you don't have the range of motion available to you. So that's why it's important to go ahead and create the range of motion so that you can then move properly, okay? Again, due to the length tension ratio. Okay, so yeah, ligaments also change with aging as well as pregnancy, for sure. So there are hormonal factors that will affect ligaments also. And the way to protect against ligaments is the secondary aligner, so to speak, because the ligaments attach bone to bone, but we also have stabilizing muscles, which are the muscles that are closest to the bones or the joints. And those muscles really are, their goal is to stabilize or hold those joints in a proper position so that the moving muscles can move properly. And the best way to go ahead and, if you have ligamentous laxity, is to try to recruit those stabilizing muscles, and that's in any joint of the body. So that is going to be your balancing type of exercises, as well as using something like kinesiotape, which can facilitate those muscles to fire, or there are even some systems with vibration or foot inserts that can stimulate the neurological sensory, the neurological sensory neurons in the foot to go ahead and facilitate that kind of contraction. So yeah, absolutely. Okay. All right, almost done. And then we'll get to demonstration. All right. So here, I use two release techniques, and the difference between the two is that the comprehensive core release technique actually both of them utilize stability. So there's a saying that you need to have stability in order to have mobility. So that's why sometimes people who are hypermobile will lack flexibility, like in their hamstrings or various different areas. And it's kind of, I say, like trying to scale a building with a rope, but the rope is not at a fixed point. It's moving across the roof of the house. So you're not able to scale it efficiently. So you're kind of all over the place. It's kind of like that with our muscle system. It's a pulley system, okay? So what we do is we try to facilitate stabilization, those core muscles that I was talking about, to facilitate a release, as well as a mechanical force that's going to be placed into the connective tissue. And comprehensive core is more kind of plain. It's a bit plainer, but it's very, very specific, where rotational release is going to involve the motion of rotation. So you actually, where you can, okay, because you can't do this everywhere in the body, but in the toes in particular, the metatarsals and the lower leg and even the femur and even the kneecap, there are a lot of joints that you can actually rotate. So again, we don't just move in two directions, we move in multiple planes. So that's why we want to incorporate rotation as well. But for this class, we're going to do the comprehensive core release technique. And I am going to go ahead and demonstrate it. If there are any questions, I can answer those before I get to it. But I'll talk about releasing tools, okay? Because one of the toughest things about releasing the foot is that the foot is far away from your hands, right? So you have to be flexible in your hips or your knees, or go into kneeling, or do a variety of things. So there are ways to kind of get around this that I'll talk about. So one is, for the metatarsal, a really good releasing tool is a standard eraser. Okay, these old kind of erasers. And you could also use this to get a little bit better grasp. Or obviously, we have the traditional pencil head erasers. So the smaller the releasing tool, the more specific. However, it is going to be exquisitely tender and painful. So if connective tissue needs to be released, it will tell you by being really tender and painful. So we call that the positive squinch test, where if I'm working on a patient, they go like this. Okay, because it hurts a lot, especially in these little tiny joints that have never been mobilized, because our fingers are too big and we're rubbing. Okay, rubbing is not an effective way to release. In my experience, it has not been an effective way to release. But the comprehensive core is super effective but it hurts like the dickens. The good news is that it will release a connective tissue in about 10 seconds or so, and it never hurts as much as it does the first time. So the more times you do it, the less tender it will be. So those are two good, these are different choices for the metatarsals. And sometimes we could even use, I have a cane out here, the underside of a cane in standing or sitting to get underneath or on top of the connective tissues. I see my cane over there. Or even a broomstick handle for the tops. So again, if you can't get into a good position, these are options. You could also go on your back and bring your knee up toward your chest. That's another option, as well as sitting, kneeling, standing, lunging. You are only limited by your creativity. So, or a lot of times, and this is a big mistake made by so many people, is they'll try to release the connective tissue in between these little tiny joints with this big old ball. And you are not going to be specific. So smaller is more specific. This is fine for a calf muscle, okay? Or a larger muscle. This is absolutely appropriate. But for the tiny connective tissues in between these guys, you want to use something that is going to fit nicely, like this guy, okay? So again, with the forefoot bunion, and lastly, this is not so great under the arch of the foot, but marbles, okay, particularly under the toe, will get very good release. Oops, slippery guy, underneath these toes in general. And again, very small, very specific. And then you're putting your weight on the releasing tool. So it's a little bit easier because you could do that in standing or sitting. Any questions? Okay.
Yeah.
Yes.
By doing this, it's an exercise you're doing with marble. Is that what it's all about? To exercise with that marble?
It's just a regular, yeah, it's just a regular marble, like the old days.
So essentially it's to strengthen, or what does it do? To separate or strengthen? What is it?
It's for releasing.
Release.
And I'm going to be showing you a video that kind of has it underneath there. But when you have a releasing tool that you're putting your weight on, like this, right?
Yep.
Is what you're going to want to do is you will then move about the releasing tool to find the tender spot. And
Right.
then you just do the comprehensive core the same way. Whereas if you're using a tool that's not resting, the releasing tool is in your hands, right? Then what you would do is you go in and then you move the releasing tool around. So when the marble or the ball is underneath, your body is moving around the imaginary clock.
Right.
Or when you're using a pencil, the pencil is going to be moving around the imaginary clock, or the other kind of eraser. Okay. All right. Good question. All right. So the comprehensive core release. I think what I'm going to do is I will talk about the goals. Okay. So again, when we're dealing with the forefoot bunion and the midfoot bunion, the goal is to widen and create mobility, better mobility in between these joints in through here, right? So typically what I found is that, again, this is the bunion joint right here. This is where the metatarsal should be, right? It should be straight, but it's actually deviated. And then the big toe compensates. Or it doesn't. It might stay straight, right? Especially in these two bunion types. In the walking bunion, it actually really deviates toward the second toe. All right. So with this, what I try to do is I make the third toe the center, okay? And then my goal is to try to take this metatarsal, which is the fifth, and the fourth, and move them away from the third metatarsal. Okay. And then I take the second and the first metatarsal and try to move them away from the third metatarsal. And I do the same thing with this bone right here, right, which is called the lateral cuneiform. Okay, this guy right here. Okay, it is in line with the third metatarsal, which makes, and the third toe. So it makes it kind of easy as a landmark to know where you're going with this release. Okay, so again, the third kind of stays stationary. We could do rotational release, and again, you want to create movement between third and fourth and third and second, and you can do a little bit. You know, every joint, every bone needs to have good mobility. If it doesn't, then you're going to get something called a stress fracture. Okay, or you'll be more likely to sprain an ankle. Because if you have disassociation, if you have movement into a position of ankle sprain throughout all of this area here, then you don't need to get your motion from this ligament right here, which is where most people sprain. So when I treat ankle sprains, I don't touch this area. I don't touch where the ankle was sprained. I work all of these joints so that they can create movement and not put so much stress on that particular area. Okay, so question is, if you don't have mobility in the toes, then you would need to open up the metatarsal, yes. And you would also need to create, again, mobility in each of these toes, guys. And this goes for every motion of the ankle. And the reason being, because the connective tissue that crosses the ankle, also, some of them go all the way to the ends of the toes. So you could be limited anywhere, like if you have a tight calf, right? So you don't have good dorsiflexion. It could be because of a reason here, anywhere before the ankle joint. So yeah, I had, and the most profound example of this is I had a patient who had cerebral palsy, and people with cerebral palsy, it's like a stroke, but it happens at birth. And this individual, like most stroke patients or people with cerebral palsy, is that they will lack the ankle's ability to get on the ground. And a lot of times they'll have to wear a brace and they'll trip over their foot, et cetera, et cetera. And a lot of times it feels like, or what we would call neurological tone. And I went in with this bias that, yeah, you know, I wasn't going to be able to do anything about it. However, I did an evaluation, passive range of motion, and I realized that the big toe was not able to move in that direction of ankle dorsiflexion. And so I did my comprehensive core release technique. She gained 5 degrees of ankle range of motion and dorsiflexion. And I never, ever, ever would have believed it, ever. So that was really, really profound because, again, the connective tissue, right, where it starts and where it ends, everywhere along that line will need to have good mobility to create fluid disassociated motion so that you don't get so much wear and tear on a particular joint. Same thing that, guys, happens with arthritis, okay? So again, if there isn't quality of movement, I look at movement like a row of dominoes, right? So if I'm trying to lift my finger, right, this is domino 1, that's 10. I need to go through each of the joints. And I could even look, because I'm trained, where I get stiff, and it's right around here. So I would just do my comprehensive core. And I could do that right now. So I go ahead and do that. Let's see if it's any different, just for fun. Okay. So now, yeah, look at that. It's more fluid. Kind of cool. So that's what we're going to be doing in our foot. And again, for bunions, every bunion is a first metatarsal problem. So we're going to focus on the first metatarsal. And again, our goal is to try to bring it away from the second metatarsal and away from the third, particularly here. Okay, right in this area. Now, another big misconception is that you always need, if I want to move something this way, right, I need to release only here. That is true, possibly, but Connective tissue, it needs to lengthen, but it also needs to shorten on the other side. So any motion could be a lengthening problem or a shortening problem. Meaning that when I just lifted my finger, right, my dysfunction could have been, restriction could have been here, but it also could have been here because this needs to shorten and this needs to lengthen. So that's why we use pain as our guideline as to whether or not to release a connective tissue. Because again, pain will tell us that that connective tissue is restricted, and then we can use the comprehensive core release or the rotational release to release the connective tissue. Questions? Any questions? Okay. All right. Okay. So let me quickly go and show this on the skeleton, and then I think I'm going to show you a video, okay, that kind of gives you an idea of how I show people how to do this on their own. So the comprehensive core release, again, if I'm going to want to get into this joint, okay, and I am, and again, I don't think I've ever palpated this area and had it not be tender on someone, okay? But again, we want to create movement throughout this particular area. So what we do is we start in between second and third toes, and then we just feel for the connective tissue by depressing our releasing tool into it. And again, we feel for tenderness. When we find a tender spot, we maintain the depth of that area of the releasing tool. And usually I press in about 80% force. We go around an imaginary clock by rotating the releasing tool, find the direction on the clock that's most tender. That is the correct direction that we're going to maintain our pressure and direction with the releasing tool. And then what we do is we apply that that stabilizing force. And usually because the bunion is unstable because it has ligamentous laxity, I like to put my stabilizing force on the bunion. And what I do is I create a compression into the tissue and I move my finger away from the body or toward the body. And whichever makes this tender spot less tender, okay, so we go from more tender, most tender to less tender. That's the force that I maintain. And then I just move. And I can move in any direction. So I can move circular, right? I can move my toes. I can move my lower leg. I can move my ankle. Another way to create stability and an easy way to do so is by pressing the flat part of the tongue on the roof of the mouth. The second question that came up is, are you working on the top of the foot only? Absolutely not. You need to work around the entire bony contour, okay? The entire connective tissue, because again, it could be a lengthening problem, it could be a shortening problem, it could be on the top, it could be on the bottom. And that's the other thing that a lot of people in clinic will do is they'll just do the underside of the foot. Not enough. Not enough. Even for something like plantar fasciitis, absolutely not. You need to move in every direction, ideally, to create quality of movement that does not cause a stress to the system. Okay, and that ability to disassociate and create movement will also absorb shock. So for you guys who are runners or have impact or knee problems or hip problems or osteoarthritis, again, those things are either an alignment problem with wear and tear and instability, and it feeds into that. I could go on forever, so I'm going to stop myself, or it could be an absorption problem. And connective tissue is their shock absorbers of your body as well. So you want to maintain that malleability or that mobility throughout the entire system. Even the organs, guys, your organs need to move. Right? Ruptured spleen, not moving. So again, really super important. In fact, I'm teaching a class, I'm offering a free class as a public service because of the virus that's going around right now and how it's attacking the respiratory system. And in particular, post-COVID patients are presenting with restrictions in their diaphragm, which could be really detrimental, not only to range of motion, but also to breathing. So again, really important to have good mobility throughout the entire body, and that is something that diminishes with age as well. Okay, so comprehensive core release. Let me now show you a video. So let's cross our fingers again that this is going to go well. And I will show you this video about addressing the first metatarsal, and it shows the top and the bottom. And let me see if I can make it bigger. And so when I give videos in programs, what they do is they kind of look like this, and you get a little picture, you tell them what you need, how you do the comprehensive core, and then the areas to go ahead and release. And then you just go ahead and watch them. Try something else. We can't get to your external storage right now. Oh no. Okay. Huh, that's no good. I will try this. I will make one last attempt on this. But let's see. Are there any questions while I'm trying to do this?
From what I've seen regarding muscle groups in the feet, ankles, calves, and that sort of thing, the only thing I really can detect is the muscle group on top of the foot that connects all 4 toes. And underneath the foot, it's not too clear on most of the graphics I've seen.
Okay, so the bottom of the foot has more of your stabilizing muscles, right? Because it's in contact with the floor. And
Well, they're connected to the heel.
yeah, a lot of them are connected to the heel, but
Right.
there, I don't know, 4 layers, I think, of muscles on the underside of the foot from the base of the skeleton outward. Whereas dorsum around the top of the foot, there aren't as many because the actions are kind of less, they're less plentiful, and they're not as important with regard to balance. The muscles on top are mostly your movers. The muscles on the bottom are mostly your stabilizers.
They're also the main motivators too, really, aren't they? The bottom of the foot.
The main what?
Motivators for your motion, I would think.
Yes, because again, you need to have stability in order to have mobility. So you want to go ahead and have that stabilization in there.
Right.
So, okay. Yeah, I think I'm just going to go ahead and have to demonstrate. This is a bummer. Wow. Yeah, I'm not actually seeing it. I have my taping. I have my, maybe this one. Let's see. No, I just have the raw footage here. I am sorry about that. I wish I had that to show you, but I can always send it to you. There we go. Yes, I can send it to you later. Yeah, absolutely. Very good. So what I will do then is I will just demonstrate this. I'm going to take my camera and just bring it into position, and then I will go into showing you rotational comprehensive core on me. All right. Camera. Take that off. And, okay. All right. So on the comprehensive core, what you're going to want to do is, again, we're going to work on that first metatarsal. So here's my foot. Everyone can see that? Yeah. Okay. I'm just going to lift this a little.
That's better.
Yeah, thank you. All right, it is very challenging to do all this like on live video. I've done it so many times that I'm pretty adept at it now, but it is like, it's almost a little frightening to answer questions and meet people from waiting rooms and do all these fun things. Okay, so again, the first metatarsal is pretty much from the ball of the foot to the height of the arch. This skeleton has a smaller foot than I do. So what I want to do is I can go ahead and feel with my releasing tool alongside of it, along the entire connective tissue, because here is where my shortening issues are going to be, right? And going all the way to the height of the arch. And, you know, for me, I found a little bit of a tender spot right here. So I depress, I go around my imaginary clock, I find the direction I take my stabilizing hands, I depress in, I move my finger away from the body or toward the body, and then I can move my toes, or I can move my lower leg in that position. And I do that for about 10 repetitions. You're more than welcome to join me on this. And then I'm going to go ahead here and yeah, good. So again, if you notice, right, if I'm a sculptor, yeah, my first metatarsal deviates inward a bit too. And so again, I'm going to go from the inside, moving into that lengthening position. This is fine. This is fine. This is starting to hurt. This really hurts. I go around my imaginary clock. I find my direction of most tenderness. I take my stabilizing hands. I make it less and I move. And then I continue until I hit that area, that bone, okay? So that then is the medial cuneiform, this bone right here. It comes into that area. So again, I'm going to kind of want to really try to get in between that, because in that area, a lot of times that medial cuneiform is a big player in bunions as well. So we do that, but that's just a different video. And we go around our imaginary clock, we go ahead and stabilize, and then we move. Okay? Now, on the underside of the foot, okay, we will kind of do that same thing. We'll start at the top and we'll feel for these tissues. A little bit of tenderness, but not bad. I can go around, stabilize, and move. And continue moving up. Again, another tender spot. I can stabilize anywhere, guys. Tongue on the roof of the mouth, anywhere. And continue in that direction. Now, for the underside, I could also go ahead and take my eraser head. Again, the bigger the releasing tool, the less specific. And go in between and get in there, go around my imaginary clock, find my direction, stabilize, and move. And continue going down. Or on this one also, a marble would not do it because it's the arch is too high. But again, for range of motion issues, I can go ahead and I'll be right back. I can use something like the J part of a cane underneath. Again, if I don't have good range of motion, I could do that in this position, or I could actually put this on the ground and go over it. There we go. We can see better now. So again, I'm going to hold, and then I move my foot around here and stabilize, and then go ahead and move. Okay? Any questions on that? So that is the comprehensive core release technique. Let me go back and just give me a second. All right. So okay, I'm back. Any questions on the comprehensive core? Anybody have any questions on that particular exercise? So that is, again, one of the two release techniques that we do. We do rotational release as well. So anybody have any questions on anything that we've covered so far? So you will do this for every toe. Yeah. Yeah. Thank you. Thank you about that. So yeah, you want to do this on every joint, ideally, to improve, again, that disassociation, that range of motion, that improved balance type of movement that occurs, as well as creating the movement to then realign the big toe properly. So any other questions on the comprehensive core release? Any other questions on the other techniques that we do in class? So, all right. Well, let's see what time it is. Yep. It is 8:35 p.m. So again, I have, you've registered for this class, so I will have a copy of your emails, and I will send you the comprehensive core release technique for the metatarsal that I meant to have for the video. And then you will have my email address that you can go ahead and respond to me if you have any questions about that technique or any other things that we do. So thank you so much for joining me. If, like I said, if questions come up, please don't hesitate to reach out. I think I had a survey on this. I've never used that function before, but if you can fill out that poll or survey, that'd be great. If you would like to provide any feedback, my email, I'm going to put it right here, is you can reach me at support@dlwalkerconsultant.com. Okay. Or the one that you registered is fixyouonline@gmail. Okay. And since you guys were notified by Fix You Online, I will send it out via Fix You Online. That way it will hopefully not get into your spam. Okay. Very good, guys. Thank you so much for joining me. Stay safe, stay healthy, and I hope to see you on another video training. Ciao.
Well, you will. Thank you.
Thank you.
Bye.
Bye.